البرزنتيشن اللي حضرتك بتقولها بتبقى متسجله وبتدخل اليوتيوب تشانل عشان الناس لو حد يسمعوها مره واثنين وثلاثه يستفيدوا منها. وكمان اللي ما قدروش يحضروا معانا بيرجعوا للمكتبه اللي فيها اليوتيوب تشانل ديت. وبرضه ظاهره هي الحقيقه ليها باع كبير جدا في المساعده لينا بصراحه فيه.
تمام، يعني يوتيوب شانل الشانل بتاعت
للويبينار.
حضرتك اللي هي فيها
اه
الحاجات
اه.
يعني مش
ده
اوبن
ده
لاي حد، اوبن للجروب بس.
لا، وكل الناس ممكن تدخل عليها، تس اوبن.
ايه ده
كل
والله؟
الجراحين. اه، كل الجراحين يقدروا يدخلوا عليها.
اوكي اوكي.
اه. فهي
كويس.
مفتوحه، والناس ما شاء الله عليها فلو كويس يعني، الحمد لله يعني.
خلاص حضرتك بقى ابعت لي اللينك وانا بشوف كمان
اه، ديفنت
التشانل دي.
ديفنت هبعتها
يلا.
لحضرتك. ديفنت احنا بنعمل السيمينار ده ويكلي، كل يوم 3 الساعه 10 بالليل. ثابت ما بيتغيرش، وده السيمينار رقم 102. فاحنا كونتينوسلي يعني شغالين فيه ان شاء الله.
ان شاء الله. توفيق ان شاء الله.
ربنا يخليك يا فندم. اه.
حضرتك هناخد questions at the end.
بعد ما نخلصي حضرتك هنفتح ال الاسئله للزملاء اللي معانا، لان عندنا كمان اسم الباثولوجي في طب اسوان موجودين عشان يسمعوا حضرتك. وعايزين برضو يعني يستفيدوا من وجودك. هم مبسوطين جدا لان هم قابلوكي في البي جي اي سي وسمعوكي في البي جي اي سي اللي فات ده، كانوا موجودين وحاضرين كلهم.
تمام تمام، ده يشرفني ان انا اشوفهم كلهم.
ربنا يخليك، شرف لينا يا دكتور عبير. منوره مصر واسوان وكل التوابع كمان.
الله يخليك، باهلها، منوره باهلها، الف شكر.
ربنا يخليك يا فندم. الاتاتشمنت لسه مفتوح يا دكتوره عبير، لو في حد عايز يعمل اتاتشمنت.
لا لا والله للاسف. اليو كي دلوقتي مقفله جدا على الاتاتشمنت من اوفرسيز.
اه.
معظم الهوسبيتال زمان كنا سهل قوي ان احنا طالما في سوبرفايزر موجود وكده. دلوقتي الهوسبيتالز نفسها بت آم، يعني حتى even within اليو كي بقت صعبة قوي.
مم.
فدي مشكلة.
الدنيا سوينجنج كل شويه بشكل.
اه it is getting harder دلوقتي جدا.
مم. عموما يعني كل واحد يعني مجتهد ربنا بيفتح له الطريق يعني.
ان شاء الله بإذن الله.
احنا جاست وان مينت بس وهنبتدي على طول يا دكتور. يا دكتور
أكيد.
عبير هاني. انا كنت سعيد جدا ان انا قابلتك قريب في البي جي اي سي يا دكتور عبير. كان يوم لطيف.
والله الشرف لينا يا دكتور إبراهيم، دايما
ربنا
بنبقى
يخليك.
سعداء إن احنا نشوف حضرتك والله.
ربنا يبارك فيك يا فندم. طيب هي الساعه بقت 10، فانا هعمل مقدمه لحضرتك وحضرتك هتبتدي على طول ان شاء الله يا دكتور عبير.
يلا.
آه بسم الله الرحمن الرحيم، والصلاه والسلام على اشرف المرسلين سيدنا ونبينا محمد صلى الله عليه وسلم. النهارده ان شاء الله السيمينار الاسبوعي اللي اسمه الجراحه طب اسوان رقم 102 على التوالي. والنهارده الحقيقه معانا ستار اوف باثولوجي، استاذتنا الدكتوره عبير
إيه.
Hello, I think I lost you دكتور إبراهيم.
دكتور إبراهيم.
معلش مش عارف اقطع ليه، ثواني.
تمام.
اه.
دكتور إبراهيم.
وايه اللي حصل؟
إحنا سامعين حضرتك دلوقتي، اتفضل.
طيب دكتور عبير معانا.
أيوة تمام.
مع
انا اسف
حضرتك.
جدا على اللي حصل، في انتربشن
مفيش
حصل.
مشكلة.
طيب بسم الله الرحمن الرحيم، والصلاه والسلام على اشرف المرسلين سيدنا ونبينا محمد صلى الله عليه وسلم. النهارده هنبتدي السيمينار الاسبوعي اللي اسمه الجراحه في طب اسوان رقم 102 على التوالي. ومشرفنا النهارده ستار اوف باثولوجي فروم يو كي ايجيبشن يو كي، بروفيسور عبير شعبان. بروفيسور عبير شعبان بروفيسور اوف باثولوجي في كوين اليزابيث هوسبيتال برمنجهام اند يونيفرسيتي اوف برمنجهام. دكتوره عبير شعبان اوريجينالي فروم طنطا، والحقيقه انها عمرها ما اتاخرت خالص عن المساعده في الكونتينوس ميديكال اديوكيشن، وهي شرفتنا في مصر لما انا عملت لنا انفيتيشن في 2014 من 12 سنه. والحقيقه ان الدكتوره عبير يعني كواليتي عالي جدا اوف باثولوجيست، من اللي ممكن كلنا نستفيد من وجودهم معانا، ومن السيرجيكال ابروتش اللي ممكن تشرحه لنا from the pathological point of view. كمان احنا بنستفيد من وجود دايما، وتعلمنا كلنا ان احنا ما بنشتغلش لوحدنا، لازم نشتغل في ام دي تي، وواحد من الاضلاع المهمه جدا في الام دي تي هو الباثولوجي. والحقيقه ان مفيش كانسر من غير باثولوجي، والقاعده الاساسيه في الام دي تي جراحه والباثولوجي والكلينيكال اونكولوجي والراديولوجي. فاحنا النهارده معانا بروفيسور عبير هتكلمنا عن البريست كانسر باثولوجي وات سيرجن نيد تو نو. ذا فلور اوف يورز بروفيسور عبير.
شكرا. Thank you very much. السلام عليكم جميعا وكل عام وأنتم بخير. It's my pleasure to speak to you today, to be with my country, my colleagues. And yeah, as Dr. Ibrahim said, I am based in Birmingham, and these are photos of where I work. So on the left side is that's the hospital where I work, the University Hospital Birmingham, Queen Elizabeth Hospital, one of the biggest in the country. And next to it is the University of Birmingham with the famous clock tower there. So if you're here anytime, just let me know. It is a nice city to be in. Dr. Ibrahim asked me today to talk to you about breast cancer and what you need to know as surgeons. And I'll try to summarize all of breast pathology in those few minutes, and hopefully will be something useful of interest to you as surgeons. So as you know, breast cancer is the most common cancer in women, but men also get breast cancer. So for every 200 women, one man would be affected by the disease. And in the UK, 1 in 8 women develop breast cancer during their lifetime. So it's a very common disease. And we do what we call triple approach using clinical examination, imaging, and pathology assessment. And how we diagnose it, usually using a conventional needle core biopsy on the left side. And we do have other more advanced techniques like mammotome biopsy, vacuum-assisted biopsy, which is mainly used for the calcification. And this is the core biopsy that we see down the microscope. So a tiny bit of tissue, this is the stroma, and the dark bits are the cancer cells that are there. So we make a diagnosis on a very small core biopsy sample. In the UK, we use the B categorization. I know that it's not used consistently everywhere in the world, but what matters is what the diagnosis is and what we do next. So on core biopsy, the B coding or categorization is from B1 to B5, with B1 as normal. So if the core biopsy is normal, we call it B1. And then this may or may not contain calcification. It's really important for pathologists to know what the radiological abnormality is. Is it a mass? Is it calcification? Is it stromal deformity? Because we always correlate. B2 is a certain benign lesion, something like a fibroadenoma, fibrocystic change, and by definition, there is no atypia there. So that's B2 benign. And these normally do not need any intervention or sometimes need excision if the patient prefers to. B3 is the uncertain malignant potential, and this encompasses a large group of lesions, some of which include atypia and some do not. So by definition, flat epithelial atypia, ADH, lobular neoplasia, all of these are atypical, but there are other lesions such as papillomas, radial scars that can be atypical or not. And here again, the treatment of choice is vacuum-assisted excision or diagnostic surgical excision. B4 is a lesion suspicious for malignancy, and this includes ADH that falls short of DCIS or florid LCIS. And then if it is definitely malignant, if it is in situ disease, it's B5A. If it is invasive, B5B. If you use that, the categorization, that's fine. If you don't, doesn't matter at all, as long as we can, as pathologists and surgeons, put the lesion in the correct categorization and act on it after that. Multidisciplinary team meetings are essential now, and we all practice this, and we all get together as surgeons, oncologists, radiologists, pathologists to discuss patients and decide on the management. So the management is no longer the decision of one person, it is a collective decision by the MDT team based on the information that we have. And if there is something I can recommend to you is to have a good request form for pathology. To get the most of your pathologist and of your report, the pathologist needs to get the best information from you as well. So this is the form that we use in Queen Elizabeth Hospital, Birmingham. And it's basically a diagram where you can draw in where the lesion or lesions are, and also a bit of clinical background, whether the lesion is screen detected, symptomatic, is it multifocal, was there history of neoadjuvant chemotherapy or neoadjuvant endocrine therapy, is there a calcification, previous biopsy, is there marker clip in situ? And basically you circle yes or no, so you don't need to write a lot. And then you put the types of the specimens here, and if it is more than one. So actually it helps a lot and saves everyone a lot of time if you agree a good request form and include as much information as possible for your pathologist. We normally, if we don't have this information, we try to look it up on our system as well. So these are essential information that are needed from the surgeons or the clinical team, the radiology, to be sent with the specimen. So it's important to know the type of specimen. Is it core biopsy? Is it vacuum assisted? Is it diagnostic excision, wide local excision, mastectomy, and so on? Laterality, is it right or left? And you will be surprised, this is a no-brainer, but sometimes we make a lot of mistakes if we don't get the side right, or if patient has bilateral disease, we really need to be very careful to get the side right. If there is multifocality, if there is a previous diagnosis, what it was, did the patient receive neoadjuvant therapy or on trial, and any unusual deviation from the standard. So if you're used to taking, for example, cavity shapes and you didn't this time, or you did something different in the surgery, it is important to inform your pathologist. And why is that? And why do pathologists need to know that? It's because the way we deal with every specimen is different depending on the clinical presentation. So for example, neoadjuvant specimens require a lot of sampling, require X-raying, for example. Mastectomies for DCIS, normally we don't see much by the naked eye. We have to X-ray the specimen. So depending on what the specimen is and what the previous diagnosis is, we deal with the specimen in a certain way. And we also sample extensively in particular lesions, particularly multifocal disease, DCIS, and post-neoadjuvant cases. And diagrams are very helpful to guide your pathologist. So surgical margins, and this is something obviously you will be most interested in. So what is the definition of a margin? The margin is non-tumorous tissue around the tumor that has been surgically removed. So anywhere where you put your knife there, the scalpel there, that is a margin. Remember that the skin is not a margin. So if we say the anterior margin is involved, this doesn't mean the skin, because the skin, you didn't cut through the skin. It's not a margin. But if you cut through and remove the skin, left the skin behind and send the subcutaneous tissue, this is a true margin. So that is important to differentiate. And in breast, relevant margins are the radial margins. So medial, lateral, superior, and inferior. Anterior and posterior are the least important because we know that anteriorly you probably go all the way up to the skin, and posteriorly we assume that you go all the way to the deep fascia. If this is not the case, then again you need to tell your pathologist, and then we anyway, if they are close, we would give you the information because you might base radiotherapy decisions on the involvement of the anterior margin, for example. And it is also useful to agree a standard orientation for the specimens. And something that is standard, so you don't need to think about it or double check it every time you receive a sample. So that's what we use here. L long is lateral, so we put a suture. The long is the lateral suture, so we know that this side is lateral. S short is superior, and M medium is medial. So easy for everyone to remember, and that's what we use, and it helps because we need to orientate every specimen we take. So these are the anterior and deep, and the skin is not an anterior margin. So what do the specimens look like? So this is an excision of a lumpectomy or diagnostic excision. Usually it's benign, not orientated. If it's not orientated, we ink it all in one color. That's black here, and we cut through. So why do pathologists ink the surface of the lesion? Just to make sure that we have got the surgical margin down the microscope. So when we look down the microscope, we would see this black ink, and then we can confirm that this is the true margin. Imagine if you got a section up to here and you didn't ink it, you wouldn't know whether you have reached actually the surface of the lesion or not. So that's the idea. We ink all the surgical margins, whether benign or malignant. And this is one for a Phyllodes tumor. So that's a diagnostic excision or a lumpectomy where you don't need to take further tissue around it. It's a lobulated leaf-like architecture here. We inked it all in green, and this is down the microscope. It has the typical appearance of a benign Phyllodes tumor. And we have different methods of dealing with the specimens and orientating them first, inking them, and slicing them. So this is an example of a small wide local excision with a long suture lateral and a short superior. There should be a medium here. And we ink them in 6 colors. So every surface would have a different color. So down the microscope, we can tell which margin is involved, if any, and we look for the lesion and we sample it. So we basically slice it along the axis like this as a long axis, and take the edges and take the samples that we need. We don't sample only the tumor, we sample around it because you need to see the margins, you need to see if DCIS extends beyond it, if there is lymphovascular invasion. So we sample a lot more than the abnormalities that we can see macroscopically. And this is another example of wide local excision inked here in black. And this is the tumor. So we would take a block here, for example, to take the tumor and the nearest surgical margin and measure the distance in millimeters. Pathologists would normally measure macroscopically and then confirm microscopically. And the gold standard is the microscopic measurement. So if they are different, the microscopic measurement is the one to go for. And generally, we measure the lesion in 3 dimensions, but we provide the largest dimension in our report because this is the one that is used for all the prognostic parameters, for the TNM staging, for the Nottingham Prognostic Index. It is the maximum dimension of the lesion. And this is just an example of how we deal with it. So we ink the specimen, slice through from one side to the other. So that's the medial margin here, that's the lateral, and this is the tumor there, pretty central. It's extending in these slices. So we would sample those and we would sample around it and the margins here, medial and lateral as well. We sometimes get sent surgical cavities. So if you as surgeons took a wide local but still felt that the lesion is close to one margin, you can take a little bit what we call cavity shave or surgical cavities. Alternatively, sometimes when we have wide local and examine it down the microscope and tell the surgeon that this is involved medial or lateral margin, they would go back for another operation and take a bit at this particular area. We normally orientate this. So we put a suture towards the inner side, that's the old cavity. So the other side becomes the more interesting, the more new margin. That's what we're interested in. So again, agree with your pathologist how you would orientate your specimen. So we always know that if you put a suture here, that is the inside of it, and then we ink the opposite side, which is the new margin that we would be interested in. This is an example of a skin-sparing mastectomy where we have an ellipse of skin with the blue dye of the sentinel lymph node, and again the sutures. Because we can tell that anterior is the skin margin, then we only need two sutures, one lateral and one superior. We don't need the medial because we can tell that this side is anterior actually. So this would be a left breast. So mastectomy, use two sutures, that is enough. And again, we ink them. So we ink the anterior surface by one color and the posterior surface another color, and slice through and select the blocks. And this is an example of a mastectomy specimen with the tumor in here. And these are the margins. This is the skin overlying. And then we sample and see what the closest margin is. So this is another one, a skin-sparing mastectomy, where you have the nipple and most of the skin is left behind. So therefore, all of this becomes a surgical margin, and we ink it. And again, the suture, long lateral, short superior. So that is now the anterior margin, the anterior subcutaneous margin. There are some examples of lesions such as DCIS, ductal carcinoma in situ, where we only see calcification, and calcification is appreciated by specimen X-raying. If we slice the specimen, we wouldn't see much. Generally, we don't see calcification. So we would slice the specimen, put it in order, X-ray it, and look for the dots, the calcification dots, and also the marker clips, if any. And then we mark where we have taken the blocks from. And it's like a piece of jigsaw. We put them back together and make a picture and size the lesion. So orientation, sometimes if it is an error, then we can get it wrong. We can get the superior inferior or medial lateral. So we really need to be clear. So for example, this is a mastectomy orientated by 3 sutures. One of them was lost before we received it. And sometimes the orientation would make a lesion left breast when you sent it as right, something like that. So before we start working on the specimen, we double check it with the surgeon if there are any errors, because once you start cutting through it, it's very difficult to go back and rectify it. So make sure that what you write on the sutures and the laterality and everything matches, because pathology would double check this first before starting on the specimen. So best practice. Generally, it's better to fill your pathology request form at the end of the operation, not at the beginning. Sometimes you plan something and change it during the operation, or change the type of specimen or the number of specimens. So after you finish, put it all on your request form. We normally try to avoid putting bilateral samples on one form. In fact, we normally try to separate them. So if you've done bilateral mastectomy, send each in a separate container on a different form to avoid the possibility of mixing up. Any unusual features in surgery, any different orientation. So say you have sent this specimen particularly with a different orientation than what you normally do, with a long is not lateral, it's medial this time. So it is important to try to alert your pathologist of that and state anything that is unusual. So I remember once we were sent a lymph node in a patient with breast cancer, but actually it was query lymphoma, not query metastatic carcinoma. And if it is a lymphoma, we send it to the specialist lymphoma team, and it saves a lot of time to know what you are looking for and what you're suspecting. The nipple, if it is left beside, it would be useful to mark the nipple site for the pathologist, particularly in the nipple sparing mastectomy, and this is particularly important for DCIS. Maybe this is probably the most important message, and if we can all work on this, this will make a big difference, and it doesn't cost us anything. Specimen transport and fixation. If a specimen is not fixed well, everything down the line will be wrong. The grade will be wrong, maybe the typing, hormone receptors, immunohistochemistry, fish, anything you do on the specimen that's not fixed will be suboptimal. And all we need to do is to make sure that the specimen goes to pathology as soon as possible. Once the specimen is out, send it as soon as possible to the pathology lab, and then it will be sliced, put in formalin, and fixed. There is nothing worse than putting a big specimen squeezing it in a bucket of small amount of formalin. What will happen is that the edge will fix, and within the tumor will die, will be necrotic. And we see sometimes things like that, and you cannot rescue it. If it is dead, it's dead. So it is important to make sure that you arrange transport as soon as possible and get it to the pathologist to deal with it soon. Small specimen, if it is a lumpectomy or axillary clearance or so, you can put it immediately in formalin, but make sure it's a big amount of formalin and it will fix well. But big specimens, wide locals, and mastectomies will need slicing and fixing. So say if you will, you're doing it and you cannot send it as soon as possible to the pathology lab, or doing it in the weekend and they are closed, what you can do is to leave the specimen not in formalin as it is, in its container, in the fridge, not in the freezer, in the fridge, without formalin. This keeps it viable till you're able to send it to the pathology lab. And actually in the UK, in some places, surgeons were asked to do the slicing and fixation themselves. And that's what they do. They were trained to do it, and they ink and slice through and leave the specimen to fix, and they send it to the pathology lab when available. So there are ways around it, but the most important thing is to make sure that we send the specimen as soon as possible and we ensure adequate fixation. So if it is a very small sample, leave it as it is. If it is a big sample, we have to slice through to allow formalin to go in. And the optimal duration of fixation is minimum of 6 hours and maximum of 72 hours. And usually bigger specimens take about a day, 1 day to fix. So less than 6 hours is suboptimal. More than that, again, is not advised. So why? Why is that? Good fixation is really important for everything. For the diagnosis, you can make mistakes if the tissue is poorly fixed. Grading will be affected. Mitotic count will decrease, so it will downgrade it. You wouldn't be able to see the lymphovascular invasion. Receptors, ER, PR, and HER2 will be incorrect. And this is an example of necrotic, poorly fixed tumor. And this is another example. That is the same tumor. The center of it is dead, is necrotic, as you see. And this is the same tumor at the edge where the formalin went through and it was well fixed. As you see, you can see the mitosis, you can see the details of the morphology, while here you cannot make much out of it. And this was actually a case that we received from one of the European countries. A patient came to be treated at our end and brought the slides with her, and they were very, very difficult to assess. It makes it really difficult for the pathologist, and we try to select the good ones that are fixed to grade on and to do the immunohistochemistry on. And again, these are poorly fixed sections, and the receptors are negative, and you cannot tell, are they negative because of the poor fixation, or is it genuine negativity? So it can be really tricky. So fixation is essential. In the axilla, if you've taken all the axillary nodes, we normally orientate the apex, so we know which is the apical lymph node, and then sample from one end to the other. Usually we bread slice the nodes. We don't just cut it in the middle. We actually bread slice in 1 to 2 millimeter intervals and assess. Levels are not done routinely. They are done at the discretion of the pathologist, and immunos are not done routinely either on the axilla unless there are suspicious cells there. So this is just to show one mastectomy and attached axillary node clearance. The apex is orientated. So we normally paint the mastectomy. We do not paint the axilla because we don't assess the margins here. We assess the margin for the mastectomy itself. And with lymph nodes, we look for every single node, no matter how small it is. We identify every node in the tissue there, and it is important, it is prognostic. So we comment on the number of the lymph nodes and how many were involved. And these are our normal cassettes. So if a small node, we just bisect it. If it's a bigger node like this, we bread slice and we put them all in the cassette. And this is our rack where we process our specimens. There are other complex cases that you do, and they are complex for us as well to assess, such as multifocal disease. If you have more than one tumor in the breast, whether in the same quadrant or in different quadrants, multicentric or multifocal, DCIS, where you cannot see much and you need to X-ray, oncoplastic specimens, and specimens following therapy, either neoadjuvant chemotherapy or neoadjuvant endocrine therapy. And for neoadjuvant specimens, there is a lot that we need to correlate together as clinical pathological teams to make sure that we get the correct information. Remember that sometimes tumors completely disappear, and before we can call tumor pathological complete response, we need to identify where the tumor was, and we need to identify the tumor bed and make sure there isn't any residual, not a single cell remaining. So we need to sample a lot, and we need to identify the tumor bed. So to start with, we need to be told that this is a post-neoadjuvant specimen. Is it part of a clinical trial that we need to deal with in a different way? And we need to know the original core biopsy result, particularly if it wasn't done on site, if the patient was referred, and whether there was lymph node involvement or not, where the tumor was, were there more than one tumor, or was it just one, and any information that are relevant, and also whether there was a clip there or not. So this is an example of a clip here, and the tumor is there, and this is a guide wire guiding you to take the tissue around it. And as you see, it is close to one margin. We have orientation clips as well, and the guide wire. And this is an example of a clip cavities, usually like a cyst down the microscope, and a small residual of island of malignant cells. And this is all tumor bed. Tumor bed is where the tumor was, the area of reaction. And we can see reaction, and we can tell that the tumor was there, and we look for even a tiny cluster of residual cells. And there are some recommended publications on that, how we deal with the pathological specimens post-neoadjuvant chemotherapy. And this is an example of wide local excision post-neoadjuvant endocrine therapy. Again, orientated, painted in 6 colors. And this is an example of male breast cancer. And we normally receive a mastectomy for it, usually obvious tumors, big tumors compared with the female breast. And this is an example, usually retroareolar, central in the breast. And it is here, and this is the dye for the sentinel lymph node biopsy. So we deal with it in the same way as the female breast. And sometimes we get some unusual shapes of oncoplastic specimens. So this is one of the examples where we would cut this end and put it, slice it, and then cut the rest. So we will have to be more creative as to how to approach these unusual specimens. We sometimes also get resections for sarcomas of the breast, like angiosarcomas. And we receive a reasonable number at our end because my hospital is a center for a regional center for the treatment of angiosarcomas. And this is usually as a complication of previous radiotherapy. And you look at it and sample it in a different way, similar to sarcoma rather than breast carcinoma, and include the margins as well. This was an example of a bilateral angiosarcoma and double mastectomy done. So there was an angiosarcoma here, that's the scar of the previous surgery, and actually it extended all the way to the other breast as well. So sometimes, yeah, you get these unusual cases. And this is what it looked like, hemorrhagic tumor. And sometimes we get muscle at the end, and we would also assess the muscle at the deep aspect, and we would tell you whether it is involved or not. And then after we do the cut-up, we would classify the breast cancer into the types you're aware of, whether it's in situ or invasive, and invasive has lots of special types. In situ carcinoma is the stage before invasion, and that's what it looks like. So it's cancer within ducts. It hasn't gone into the adjacent stroma or into the parenchymal fat. Microinvasive carcinoma is invasion that is less or equal to 1 millimeter. Usually we see it in the context of high-grade DCIS. So you see a lot of DCIS there, and we really look hard for any evidence of small invasive disease, and here as well. So this is DCIS and really a tiny invasion there, less than 1 millimeter. So that's what we call microinvasion or microinvasive carcinoma. So microinvasion, that's the current definition and can be more than one focus. And on core biopsy, we still call it B5A, similar to DCIS. On excision, it is staged at PT1 MIC micro, as per the WHO book. Just some examples of no special type. That's the commonest type of breast cancer. And by the way, the term ductal is no longer used. We do not use it, and the WHO book does not recommend it. So we should call it no special type cancer, but we understand that that's what we used to call ductal carcinoma. Mucinous, lobular, ecadherine, yeah, so now we call it NST. Medullary carcinoma is no longer a type. We call it's also under no special type carcinoma with medullary features. So it's not as a separate type anymore in the pathology guidelines. Lobular carcinoma, we know that it should show ecadherine loss of expression, but not always. And this is something we should all be aware of. Sometimes in a proportion of cases, up to 15%, we get what we call aberrant ecadherine expression. So sometimes we get a little bit of expression in lobular, and this doesn't mean it's ductal. So the diagnosis is morphological. Similarly, high-grade ductal NST carcinoma can be ecadherine negative. So ecadherine doesn't make it ductal or lobular. It helps in some cases, but it's not an absolute criterion. And there are special types of breast cancer now that have molecular phenotype, so we can confirm it by molecular testing. And these are generally the low-grade triple negative breast cancers. So for every breast cancer, we grade it. and this is prognostic. Just to show you the difference between grade 1 and grade 3 carcinoma. What about the margin? So margin, as we said, we ink it. So DCIS, if it is at the margin, you will need to go back and clear a bit more or do a mastectomy. And sometimes we get a little bit of calcification, but down the microscope, we see a lot of DCIS that go up to the margin. So sometimes the radiological pathological correlation is not great, and that's because sometimes DCIS is non-calcified. So while we pick up on radiology the calcified DCIS, here, for example, the DCIS shows no calcification, and that's why it can be more extensive than what we think radiologically. If we have invasion and DCIS, we measure the margin to the invasive and to the DCIS. In this case, the invasion is clear. There is a space here to the margin, while the DCIS is the one at the margin. So this means that it's involved and we will need to take more tissue. Standard for pure DCIS, 2 millimeters margins are required, while for invasive carcinoma, 1 millimeter margin. And that is, it's also shown that larger margins do not offer any further reduction of local recurrences. So these are the current guidelines, and that's what we follow as well in the UK, according to NICE guidance. Nodal metastases, sometimes they are multifocal, and we give you the maximum dimension of it. And sometimes we do cytokeratin immunohistochemistry to give us an idea about the extent. And as you see, it's a lot more sometimes than what you can appreciate on H&E sections. And the morphological prognostic factors are tumor size, nodal status, and tumor grade. So the stage, TNM stage, and the latest, the 9th edition, had just been published, and we follow it from January this year. So we talk about the tumor size and the lymph node status. So this is the tumor. P means pathological, and that is to differentiate it from the clinical TNM stage. So there is one clinical radiological, but the gold standard is the pathological TNM. So P, pathology. If it is in situ disease, it's PTIS. If it is stage 1, it's up to 20 millimeters. 2 is 2 to 5 centimeters. PT4 is when it ulcerates through the skin or like inflammatory breast cancer. So for every tumor on excision, we would categorize it into one of these. So a PT and PN and M is for metastasis. And as you know, for every breast cancer, we do hormone receptors, ER and PR, and HER2, and we normally do them on core biopsy, on the original core biopsy. And for this, we use immunohistochemistry and also in situ hybridization for the equivocal cases. Just to show you what they look like, so ER is a nuclear receptor and PR is the same. This is positive, this is negative. HER2, this is a HER2 positive tumor, strong membrane positivity. That's a negative one. And that's when we use FISH or D-dish in situ hybridization techniques to assess for the HER2 amplification in breast cancer. When do we say the tumor is ER positive? The cutoff value now, the accepted by ASCO-CAP guidelines, UK, European guidelines, all guidelines is 1% positivity, regardless of the intensity of staining. So we don't need to take into account whether it's strong, moderate, or weak. If there is 1% and above, that is ER positive. However, we understand that there is a group that will express low level of ER. That's what we call ER low positive, from 1 to 10%. And these sometimes behave biologically as ER negative. And actually now they enroll those patients into triple negative trials as well. We used to use the Allred score or the quick score, which comprises the intensity and percentage. You can still provide it, but be aware that the cutoff is now based just on the percentage. And sometimes on the lower scores, 4 out of 8, for example, can be negative. If it is less than 1%, strong staining, this is an Allred score 4 out of 8. That's still negative based on the intensity. HER2 3+ is strong complete membrane positivity in more than 10% of cells. And this helps us to classify tumors into luminal, that's the ER hormone receptor positive, triple negative, or HER2 positive tumors. We also do tumor profiling, multi-gene profiling, particularly for the intermediate risk groups. So, for example, low-grade tumors and low-risk tumors will not receive chemotherapy. High-risk tumors with node positivity would receive chemotherapy. And we are left with a group in the middle that traditionally received chemotherapy, but only few of them needed it. So at the moment, we only apply the multi-gene tests such as Oncotype DX testing or Presigna or EndoPredict to this intermediate group, and that's in the ER positive, HER2 negative breast cancer, just to see whether they benefit from chemotherapy or not. We give neoadjuvant chemotherapy to triple negative breast cancer, HER2 positive breast cancer, inflammatory breast cancer, and some types of ER positive, node positive breast cancer. There are types of triple negative breast cancer. Not all of them are really poor prognosis. There are certain types that are indolent and of good prognosis, and these are examples of them. So if you have these, do not go for neoadjuvant chemotherapy, go for surgical excision. And include clips, always clips when we deal with neoadjuvant chemotherapy. These are the updated UK recommendations for HER2 assessment in breast cancer. And for the pathologists in the audience, there's really a very helpful diagram there to help you designate which category it is. So you need to just assess the intensity percentage and follow the diagram, and it will tell you which category to use. And there are some minor differences between the ASCO-CAP guidelines and the UK HER2 scoring guidelines, very minor in a small group of patients. So we test prospectively on every single primary breast cancer, and we also test in the metastatic and recurrent disease. We do immunohistochemistry mainly. FISH testing is only done on the 2+. And core biopsy is reliable for the assessment of ER, PR, and HER2. And we used to say it's either positive or negative. Positive is the 3+ or the amplified 2+, and the rest is negative. But now we know that we have another category called HER2 low breast cancer, which is the 1+, or the HER2 2+ FISH negative. And these benefit from antibody drug conjugates. So there is a drug for them now, particularly in the metastatic setting. HER2 is not always easy to interpret, and we get cases with heterogeneous expression. So now, instead of having just a positive and negative category, we have different categories. So HER2 low and even ultra low as well. And they are treated by Enhertu trastuzumab deruxtecan drug, which is an antibody drug conjugate. So there is a bit of inconsistency among pathologists as whether we should use the HER2 low category or not. ASCO-CAP do not recommend using it by pathologists, while the UK and Europe do use it. So we would use the term HER2 low breast cancer. We repeat testing after neoadjuvant endocrine therapy and chemotherapy because there is evidence that sometimes receptors change after treatment. So they can go from positive to negative or negative to positive. And that's why we repeat testing for ER, PR, and HER2 following treatment. PDL1, that is again a new development, and it's something that we now as pathologists assess in the context of metastatic or recurrent triple negative breast cancer. So now every molecular profile would have different tests that we would do on. So if a triple negative breast cancer metastasizes or relapses, we do PDL1 testing, and we have two tests, and each test is specific for a particular drug. So oncologists would ask us to do. We normally do both and give them the option, but you can start with one, and if negative, do the other one. So this is PDL1, which is not looking at the cancer itself. It's looking at the immune cell environment within the cancer. So this is basically the lymphocytes within the tumor, within the stroma, not the cancer cells themselves. And this is one test, and this is another test, and each one has a different method of scoring. Ki-67, I know it is done routinely in certain parts of the world, but it's not currently recommended in most of the guidelines because of the lack of consistency of pathologist reporting. So it's not in the ASCO-CAP guidelines, not in the UK guidelines, not mandated. So we don't do it routinely. We now actually try to use image analysis and artificial intelligence in the assessment. To do it properly, you need to count well, to count quite a few cells. And there are different cutoff values for Ki-67 positivity. So watch this space. We are using more and more of image analysis to assess that. There are other molecular tests that we do that are specific for, can give you information of what drug the patients can take as well. And these are some examples. I'd just like to finish with our new baby now, digital pathology, and it's something that we as pathologists are very excited about. We no longer use a microscope all the time. In fact, I've been diagnosing digitally for over 2 years now, and this is my screen at work. And there are lots of advantages of digital pathology. It's actually quicker to assess the cases. So I can see all my slides here, not put them on trays and take a slide by slide. And you can magnify, you can put the immunohistochemistry slide next to the H&E slide. You can measure the size, you can measure to the margin, really easy. You can use it for teaching, for MDTs, for presentations, and you can use it as well to apply artificial intelligence algorithm, AI algorithm, and it's really fun to use as well. So until recently, we hadn't been able to apply it until it was approved by the UK government to assess cancer screening slides. So this includes breast cancer, colorectal cancer, because it was shown that from evidence and from studies that the quality and the diagnosis based on digital pathology is not inferior to that down the microscope. And in breast pathology, there are lots of models now that are available, some of them for diagnosis, some for classification, some are prediction and prognosis, some for biomarker analysis, and I think this is one of the most important ones. I don't think we need a machine to diagnose for us. In fact, there is a lot of incorrect diagnoses by the machine, but we would like an algorithm to help us and make us quicker in assessment of some markers such as Ki-67 and HER2 that take a lot of our time as well. It's still early, it's still in its infancy, we're still collecting data, but there are lots of algorithms in the market, and they are quite expensive as well, but I think we need to show that they provide added value to what we do. So this is a company that provides all these solutions for breast. So all the markers can be assessed in there. However, when you implement it, the experience is variable, and sometimes you actually introduce another step of scanning and quality assurance. So it sometimes prolongs the time. It's quite expensive. So this is a study that showed that you have to have at least 5 million euros as a setup to start digital pathology. That is just to set it up, and then the continuous as well expenses. The other thing is that we don't have quality assurance yet for these AIs. You don't know whether they are doing it right or wrong. And this is a very recent paper on HER2 scoring by 10 available algorithms. Some are commercially available, and you see that they are very inconsistent. In fact, the consistency among pathologists is much higher than among AI algorithms. So before we apply a particular algorithm, we really need to validate it and to compare it to our manual assessment before you spend millions on it as well. So just to summarize, digital pathology and AI in pathology, lots of advantages. It's a tool, a diagnostic aid. It's useful for fast biomarker assessment. It allows flexible working. When you have your setup at home or even in another country, you can work from anywhere, which is very helpful. Useful for second opinions, for sharing, for education and presentation. But there are still lots of disadvantages. It requires validation, requires investment, requires training. Pathologists have to be trained quite a lot to be confident in making a diagnosis on the screen and to let go of their microscope. It obviously, the machine can get it wrong, and who would take the responsibility? There are ethical issues there. And the impact on pathologist training. And we don't want to be over-reliant. If you're not experienced enough, and the algorithm would give you a diagnosis that's different from what you think it is, that is dangerous as well. So there is a lot to consider when you implement digital pathology. So it is an assisting tool. It's not a replacement of the human pathologist. It's something that will help us, but it will not replace your pathologist. And that's it. And yeah, I hope I've tried to summarize all of pathology in 1 hour, which is a bit tricky, but I hope you've got the message, and I'm happy to take any questions.
الحقيقه كالعاده دكتوره عبير يعني ممتعه ويعني to the point and very informative session والمختصر المفيد. حقيقه يعني انا شاكر لحضرتك جدا السيشن الممتع اللي حضرتك سهلت فيه حاجات كتير جدا. وانا عايز اقول لحضرتك ان الناس عماله يبعتوا مسج زي لو حضرتك حابه تشوفيها. مبسوطين جدا بالفيري جود فيدباك.
Thank you. Really
في
appreciate it.
هستاذن حضرتك بس نفتح شويه اسئله الزملاء
Yes.
اللي هم يعني ليهم اسئله هنفتحها.
Yeah.
لو حد عايز يدخل يتكلم هو يا شباب يتفضل، وانا هقرا الاسئله اللي جت يعني. تغيب بيقول لحضرتك اميزنج ليكتشر. احمد اسماعيل بيشكر حضرتك بيقول ثانك يو. احمد بيقول لحضرتك at which magnification you assess HER2 intensity.
Okay, that's a very good question. So generally we start low power, and then you assess whether you can see any staining or not. So if at the very low power you can see the staining, this is likely to be strong. If you need to go another power higher, say times 10, to see it, that's usually moderate. If you then can't see anything, we go for the highest power. If you can only see it at times 40, then that's weak or faint staining. So actually it's called the magnification rule, and the magnification rule actually tells you the intensity depending on how easy it is to assess it from low to intermediate to high magnification. And if it is strong and 3+, we normally don't need to go higher. But if it is weak, we have to go times 40 to assess it.
اوكي. في حد تاني حابب؟ اتفضلي يا دكتور عبير لو في حاجه حضرتك عايز. دكتور عبير في
ايوه.
حضرتك عايز تكملي حاجه ولا افتح الاسئله التانيه؟
لا اتفضل حضرتك، لو في اي
اوكي.
اسئله اتفضل.
انا في سؤال لي انا بقى تاني، وده سؤال كومون وريكارنت، وما يعني ما فيش ميتنج بنعمله الا لما نساله. ذا مارجنز still the margins is a very debatable لغايه دلوقتي. انا I know that the all the facts that 2 millimeter is enough for as a safety margin for this IS, and 1 millimeter is enough for invasive form. Also, there is no tumor, ink in tumor is the base of negative safety margin. Still, till now, the negativity of this IS is very, very challenging techniques. We cannot justify the DCIS negative margin. Almost of this IS, it's a positive margin, and we are taking another pathology, another shaving is positive margin. When we are taking another shaving for the ages, it's a positive margin. How can we deal with this problem?
Yeah, it is a big problem and we all face it. I think to minimize it, I don't think we can eradicate it. To minimize it, it is with good preoperative workup of the case to try to assess radiologically. In the UK, the recommendation is that if you have a large area of calcification, that we sample 2 areas or the most suspicious core biopsies before we go to get the extent of it. And sometimes we also do MRI to assess the extent, because MRI is really good, particularly in high grade DCIS, to assess the size. But the problem is sometimes DCIS is non-calcified and it doesn't show up on radiology. So that's where it's difficult, and we go once, sometimes twice, 3 times, and then end up with a mastectomy because it's not visible. It's much more extensive than we know. So yeah, work up well with radiology, MRI in suspicious cases, more than one biopsy, but still there will be cases that will be positive margin regardless of all of that. The other thing as well is a question sometimes we get asked: why is DCIS is in situ disease? Why we would recommend a higher margin, wider margin for DCIS and only just 1 millimeter for invasion? What's the rationale? And the reason behind that is that the treatment of DCIS is surgical. That's it. We remove it. But the treatment of invasive cancer is usually with adjuvant therapy as well. So we give endocrine therapy. We might give anti-HER2, sometimes give chemotherapy in addition to radiotherapy. So there are other modalities that we use for invasive cancer, and that's why 1 millimeter would be enough, because we would tackle the tumor with other things. While, as you said, Dr. Ibrahim, for DCIS, you need to get a clear margin, and sometimes it is difficult. It doesn't happen.
Okay. Thank you for your answer. Another question. Chat. What is now the adequate margin for phylloid tumors?
Yeah, excellent question. And actually, the Association of Breast Surgeons in the UK, the ABS, have recently published a paper on that, on adequate margin for a phyllodes tumor. So basically, it depends on what type of phyllodes tumor it is. If it is a benign phyllodes tumor, then you just need to take it out with the capsule. There is no need for further margin. Just excise it with a capsule. And this is usually the B3 lesion when we say it could be cellular fibroadenoma. Benign phyllodes cannot be excluded. So surgical excision is enough with the capsule. That's it. Even if it is at the margin, we normally do not go back. It's a benign one. For malignant phyllodes, the recommendation is 10 millimeter margin. And some say that at least it is 5 millimeter, and you can discuss with the patient between 5 and 10, but not less than 5. Borderline phyllodes, usually it's 3 to 5 millimeters. Again, it's all detailed in this paper, and it takes into account as well the age of the patient, the size of the lesion, In big lesions, we can also give radiotherapy after that. But the message is malignant phyllodes 10 millimeters at least.
Okay, 10 millimeter is adequate for phylloids.
Yeah,
10
for
millimeter.
yeah.
اوكي. يعني انا عارف طبعا. احنا دايما كان بيتشرح لنا ان الفيلويد 3 تايبس، عندنا بناين 1، عندنا انترميديت 1، وعندنا مالجننت 1. سو احنا في الانترميديت وفي المالجننت لازم ناخد 1 ملم 1 سنتيمتر or 10 millimeter safety margin, which is enough to be adequate to avoid a lot of local recurrence or the pathological terms. But the phylloid still a challenging problem, because we have a lot of cases in younger age with huge phylloids, and most of the pathology, it looks to be benign, which is very strange. I have a series of female in teenager. I do a breast endoplastry for there, because they still very young, and they need their breast, and try to preserve what can I preserve of breast tissue after removing the phylloids, and also the shape, the aesthetic part of the surgery is very important to this age. طيب. Another question: a breast carcinoma show the following immunohistochemistry profile: ER positive, BR low positive, HER2 negative, high KI67 index. How it can be classified and interpreted. دكتورة إسراء دي دكتورة إسراء مدرس مساعد معانا في طب أسوان، وهي بتسأل حضرتك لما يكون عندنا ER positive والبي ار low والهير 2 نيجاتيف كي اي 6 7 هاي، تقدر هي تصنفها ازاي؟ how can be classified and interpreted.
Yeah, so this is likely to be luminal B breast
B,
cancer. So it is
yes.
still ER positive but high Ki67. So these tumors, obviously, we will look for the grade as well. We would look for the lymph node status, the type of cancer. But these normally respond less well to endocrine therapy and more to chemotherapy. So if this tumor is if the patient, for example, is node positive, then there is more likelihood to respond to chemotherapy than the standard. But again, it's ER positive, so it can receive endocrine therapy. So we would look at the other parameters. And as I told you, Dr. Isra, we don't do Ki67 routinely, because we know that the assessment by estimation is not reliable generally. Although high Ki67, if it's very high, all of us will probably get it right. So we sometimes use it, yeah, in this context, and it is used recently as well at a cutoff of 20% for ribociclib treatment for high risk ER positive breast cancer, HER2 negative breast cancer as well. So you can actually use Ki67 in various ways. Some use it to direct neoadjuvant chemotherapy. Some use it for high risk ER positive to indicate that this patient is high risk. And now we have ribociclib as a drug to use in addition to aromatase inhibitors on those patients.
inhibitor. لا. Yes. يعني انا بس يعني عايز، يعني طبعا حضرتك جبت المفيد، لكن انا عايز بس اعيد تاني ان الام دي تي زي ما حضرتك قلت از فيري امبورتنت. ما نقدرش نفصل العيان على الباثولوجي لوحده، لازم ناخد كل الداتا بتاع العيان بري وانترا وبوست. السيتويشن بتاعنا كله على بعضه لازم نفصل له العلاج بتاعه حسب السيتويشن بتاعته. والحقيقه ان ما نقدرش نغفل الليمف نود ستيتس، ولا نغفل الايدجز، النيجاتيفيتي والبوزيتيفيتي اوف ذا ايجز. ما نقدرش نغفل طبعا الاميونوهيستوكيمستري والكاي 67. بالرغم ان الكاي 67 حضرتك قلت من شويه ان احنا ممكن ما يبقاش ريكومندد في كل الحالات، لكن البريفتيف اندكس اوف كي اي 67 ستيل يعني indicated in a lot of countries. آم،
Yeah, particularly لو ما فيش access للمالتي جين testing. If there is
اه
no access للoncotype and multi gene testing key 67 with the grade and as you said with all the other, and also the age of the patient, if she's a young patient or if
yes
she's postmenopausal, for example.
yes.
So yeah, all of this to be taken into account. Absolutely. Yeah.
بس هو الجين تيستنج is very difficult to be done here يعني. it's very يعني حضرتك عارفه ان ده هيبقى صعب جدا ان يبقى available في كل الاماكن، وانه كمان مكلف للغايه. فاحنا ممكن
Yeah.
نستخدم الحاجات اللي نقدر نستخدمها ونمانج according للسيتويشن الموجود.
Yeah.
طيب،
Yes.
دكتوره تغريد امين دي مدرس معانا في باثولوجي في اسوان، بتقول لحضرتك what about HER2 positivity in DCIS in spite of its negativity in invasive tumor cell.
Yeah, that's a proper pathology question, Dr. Tabrid.
اه
Yes.
طبعا.
Yes. So yeah, you can get that. And we actually use HER2 positivity to confirm the diagnosis of DCIS if in doubt. But sometimes, yeah, you're right. Sometimes you find that the DCIS is positive, but the next step it has been lost in the invasive tumor. It can happen. It's not common, but it does happen. And we normally do not assess, obviously, or base treatment decision on DCIS status. We only base it on the invasive. So we would discard the DCIS, but knowing that it can happen that the DCIS is positive and then the tumor loses it when it becomes invasive. And I personally use DCIS, HER2, actually a lot to confirm that it is DCIS in the difficult cases, particularly the apocrine tumors, when you cannot use ER and CK5 or CK14. Hope this answers your question.
دكتور عبير، معلش انا دكتوره شيماء بيبرس. انا قابلت
اهلا
حضرتك
وسهلا.
كتير قبل كده في المؤتمرات، واخر مره كان ليا الشرف اني اتكلمت مع حضرتك. هفكرك ان احنا من طنطا احنا الاثنين. اهلا بيكي
أهلا وسهلا.
مع حضرتك. انا بس
كده
هتكلم على
كده
الحاله
احنا
اللي
نخرج منها بقى يا شيماء،
لا لا
نخرج احنا
اسفه
منها
والله، لا
كده.
ابدا يا دكتور ابراهيم. انا بشكرك ان انت جبت لنا دكتوره عبير عندنا، يعني ده شرف لينا والله انها نورتنا
دكتوره
هنا
شيماء
النهارده.
رئيس قسم الباثولوجي في اسوان، في طب اسوان، يا دكتوره عبير.
أهلا وسهلا،
لا
تشرفت. وإحنا فعلا اتقابلنا
ايوه
definitely.
صح. انا بس عايزه اقول لحضرتك الحاله اللي بتقول عليها دكتوره تغريد. اكشولي الحاله يعني هو بتسال على ايه، على لو انا اعتقد ان دي الحاله كانت بتسال عليها ان يكون دي سي اي اس بوزيتيف، وده اصلا احنا عارفين ان هير 2 باي يعني من غير اي حاجه كده لازم يبقى بوزيتيف في الدي سي اي اس. بس لو انا لقيته في الدي سي اي اس ومش معايا، مش بوزيتيف في الانفيزيف اللي معاه، مش في كور، وبعد ما خدنا عملنا اكسيشن لقيناه، لا ده هو في نفس الحاله دي. هل دي بتبقى من الماركر نفسها في مشكلة، ولا ده ممكن يحصل؟ يعني احنا لقينا حالة كده بالفعل.
لا ممكن يحصل، ممكن يحصل.
تمام تمام.
It's not something wrong with the testing.
اه
Sometimes you get it. And also DCIS is not always HER2 positive. It's only the high grade DCIS. Only
يس
the high grade
ايوه انا
DCIS.
عارفه، اه صح،
Yeah.
حضرتك
Yeah. Yeah.
تمام. انا بشكر حضرتك ان حضرتك قلتي ان احنا لازم، انا بس هقول الحاجات اللي بتحصل معانا، ان احنا الريكوست لازم يبقى كومبليت ريكوست ونيجي لنا كل الداتا، ان احنا مش بنشخص، احنا مش بنقرا شريحه، احنا بنشخص عيان، فاحنا محتاجين كل الداتا. وبشكرك على الانتنسي حضرتك قلتي عليها في كل وضحتي الفيكسيشن واهميه الفيكسيشن والفورمالين فيكسد، عشان ده بيأثر معانا في كل الشغل بتاع الباثولوجي لغايه ما بيطلع في الاخر. بشكر حضرتك على ده. والمارجنز، وقد ايه احنا المارجنز، على فكره المارجنز طبعا ساعات بيبقى الجراح كتر خيره عمل شغل جامد جدا، وان دي سي اي اس ده مش بايدين حد، ما حدش هيشوفه، هو مايكروسكوبيك، فما حدش يقدر يعني تو بريدكت اصلا اذا كان موجود او لا. وان احنا يا ريت يعني يبقى في اورينتيشن ان الستيتشز اللي موجوده يبقى محطوطه صح ويتقال لنا صح. بشكرك، انت قلتي كل الكلام اللي كان نفسي اقوله، وشرفتينا ونورتينا مع
الله
هنا.
يخليكي، ألف شكر. and I think لو هنطلع بس من يعني اللقاء ده بحاجة واحدة، ال good communication between the pathologist and the surgeon. It will save everyone a lot of time. It will give you the reports that you really need. It will give you all the information. Just good communication. Tell your pathologist the information. As Dr. Shaimak said, we don't provide a diagnosis, we provide an opinion. And the opinion is based on multiple parameters, one of which is looking down the microscope, but also we take into account the clinical presentation, radiology. Is it representative or not? You might get a biopsy and it looks benign down the microscope, but if the radiologist thinks it's cancer, that's non-correlating. We have to feed back and say, no, actually get another biopsy. This is not representative. So I think unless we all talk together, we will not do well. And the fixation, I've seen it myself. I've seen how it can be really difficult for the pathologist to make anything out of a specimen if it's not well fixed. And it will not cost us anything. It's just making sure the transport, getting it quickly to the pathologist, slicing and fixing. It's not rocket science. It wouldn't cost us anything. It's just adequate and good communication between the surgeons and pathologists. And these are the successful teams that work together, getting us together and working well together. بالتوفيق إن شاء الله.
دكتور
الحقيقه
عبير
دكتور
مساء
عبير
الخير.
دكتور عبير ان الام
دكتور
دي تي
عبير
حل هذه المشكله. الحقيقه وجود، انا اسف، مين معانا عايز يتكلم بس؟
انا الدكتور
آسف.
احمد انا الدكتور احمد عبد العزيز، استاذ الباثولوجي في القصر العيني. دكتور
اهلا يا
عبير
استاذ.
شكرا
أهلا
اهلا
شكرا
وسهلا.
جزيلا على المحاضره الجميله ديت. ربنا يكرم حضرتك، دايما بتمتعينا بمحاضراتك. انا كان بس ليا سؤال، الرول بتاع الكي اي 67 في اللودس تيومر، ان في ساعات بتبقى طبعا صعب انك انت تعدي الميتوتيك فيجرز وبتاع. هل حضرتك تستخدميه يعني كديفرنشيت بين البناين او البوردر لاين او المالجننت؟
لا الحقيقة لا،
point.
لأن ما فيش evidence as to where the cutoff between them is. That's the problem. It is a collection of features and weighing which way to go. And the WHO book, actually the current one, the coming one, the 6th edition, is going to change our criteria for malignant phyllodes. So the previous edition, 2019, said that you have to have all the features, 5 features all have to be there: infiltration, overgrowth, atypia, mitosis, cellularity. This edition is going to say only 4 will be fine, to call it malignant phyllodes. But the problem with Ki67 is we cannot tell. If it is very high, that's helpful. But if it is like around 20%, there is, you cannot differentiate based on whether it is benign or borderline because they overlap. So we don't normally use Ki67 in this context, but phyllodes are difficult and the definitions are evolving, and I personally rely on the mitotic count, still count it, and the rest of the features. Is there a leaf-like architectures, cellularity, overgrowth, infiltration, all of that, and see which way, how many we have and which way to go. But they are difficult, Dr. Ahmed, as you know.
شكرا يا فندم، وكل سنه وحضرتك طيبه ورمضان كريم.
حضرتك طيب.
نورتنا يا دكتور احمد بيه.
ربنا يكرمك يا دكتور ابراهيم، شكرا جزيلا.
طيب في سؤال تاني يا دكتور عبير. مالتي فوكال بريست كانسر, you want to do receptors for both.
Yes. So if we think there are multiple primaries, yes, we would do receptors for each one. But something like, for example, invasive lobular carcinomas, where you have satellites, all of them are the same, we don't normally do it on all. But if you think they are different tumors, multifocal, multicentric, particularly if they are different type, different grade, we would do ERPR on everyone because they can be different.
وبقيه السؤال كاتب in multi gene assay for multifocal lesion we do for each tumor alone.
Yes. So in multi-gene assay, to make it cost effective, we normally start with the poor prognosis one, with the worst one. So the worst grade, for example, if you have grade 2 and grade 3, start with grade 3. If you have both grade 2, start with the largest tumor. If this comes back as low risk, then we test the next one. And the Oncotype DX, by the way, do it for free on the second tumor. So they start with the first one. If it is high, that's fine. You don't need to do any more. If it is low, they actually do the second one for the same price as one. But that's, yeah, exactly. That's how we do. We do one first. And if the result is low score, we do the next one.
تمام. سؤال تاني معلش، احنا اسفين طولنا على حضرتك.
لا لا، تحت أمرك.
What is the difference between HER2 enriched and HER2 positive?
Right, so HER2 enriched nearly the same, but HER2 enriched is usually used when you do genomic tests, not immunohistochemistry. So in the original paper by Pirot et al., when they did the genomics of breast cancer and classified the tumors into luminal A, B, this was genomics. This wasn't immunohistochemistry. When we try to do the same by immunohistochemistry, we call it HER2 positive or negative. So while the majority of HER2 enriched tumors will be HER2 positive, they are not all HER2 positive because this is a technique and this is another technique.
طيب غالبا ده سؤال جراحين فهو بقى عايز يفهم يعني. برضو ده سؤال جراحين برضو. Margins for invasive carcinoma اللي انا سألت حضرتك عليه. No ink or 1 millimeter.
Okay, tricky one. So low, no tumor on ink is the American classification. That's what the US believes in, and this is based on their systematic review and meta-analysis, and that's what they believe. No tumor on ink or no ink on tumor, that is for them is enough. The rest of the world, including Europe and the UK, yourself, I think most of us would think that that's not enough, and we would go for 1 millimeter clear margin, not tumor on ink. So in the UK, we do not believe in tumor on ink, and but it's in the US that is their criteria, and that's what they do.
Yes. Yes. هو برضه هيبقى صعب ان حد جراح يشيل 1 ملم بالظبط حوالين ذا تيومر. هو ده حاجه بتبقى صعبه، لكن هو ده بيجي في السلايسز بتاع الباثولوجيست لما يجي يقطع بقى، هو بيدور على 1 ملم اور مور. لكن
Yes.
ده بس اللي انا لكن احنا عاده بعد الاونكوبلاستيك بريست سيرجي بروسيدرز ما عندناش بندور على 1 ملم، لان احنا بيبقى عندنا يعني اللايبيليتي ان احنا نقدر نشيل جود سيفتي مارج وذ
Yeah.
اثيتيك بار.
Yeah.
لكن هو الحقيقه ان المشكله الحقيقيه مش في الانفيزيف. الانفيزيف خلاص احنا معروف نهايتها فين، واعمل شيفنج تاني. لو هي القصه كلها في الدي سي اي اس، الدي سي اي اس بنقعد نجري وراه كل ما نعمل شيفنج. وزي ما حضرتك قلت كده ان احنا لازم نعمل فيري جود اسسمنت اند فيري جود بلاننج بري اوبراتيف اند انتر اوبراتيف،
Yeah.
وده بيقلل فعلا مش بيمنع. لكن ما فيش مشكله يعني المشكله دي بتاعت الدي سي اس اتس نوت بريفنتبل all over the world، لكن you can decrease the incidence of DCIS positive margin. هو
Yes,
كاتب تاني
absolutely.
DCIS and invasive margin no ink not 2 ملم. لا ما هو خلاص ما عنديش شرحت خلاص. اوكي، في اي
And
اسئله
by
تانية؟
the way, 2 millimeters applies to pure DCIS. Pure, لو DCIS on its own. But if we have DCIS and invasive disease, it's still 1 millimeter. So
Yes.
that's again small print, but that's what the guidelines say. So the 2 millimeter is only for pure DCIS.
انا والله سعيد ان الاسئله بدات تبقى في العمق كده، ده انا سعيد جدا بالزملاء اللي بيسالوا بالطريقه دي. طيب في حد تاني من الزملاء اللي هو اي اسئله؟ علشان انا عارف ان توقيت مختلف بيننا وبين انجلترا دلوقتي، في ساعتين بيننا وبينهم. فطرتي ولا لسه صايم؟
لا الحمد لله فطرت. لا ده good timing ده بالنسبة لي، الحمد لله.
طب كويس كويس. انا هبقى زعلان لو كنا عطلناك على الفطار. طيب
لا لا.
when to do immunohistochemistry over axillary nodes?
Good. Yeah. We don't do it routinely, but we
مم.
have a low threshold for doing it. So if
اه
you have any suspicion that there is, or whether some collection of cells, is it histiocytes or not, we would do. Also, we
اه
have very low index of suspicion in the neoadjuvant setting. So if you have a lymph node after neoadjuvant chemotherapy with a bit of fibrosis and what looks like a tumor response, we generally would do on a section or so just to make sure that there is no residual disease. So the guidelines say you don't have to do it on every single lymph node, but if there is on the initial scanning on the H&E, if there is suspicion, we would do it, and we wouldn't do levels routinely either. So when we started sentinel lymph node in the UK, for every tumor we used to do 3 levels, and cytokeratin immunohistochemistry at level 2. And then we had a lot of data showing that we actually don't detect much. If you haven't seen it on H&E, you probably there is no need to do this. The other thing is that there are some algorithms now for AI, digital pathology and AI, that actually do the lymph node assessment as well. So we might in the future, screen them by the AI to pick the tiny bits of mets.
اوكي. انا عندي سؤال لحضرتك بقى، يعني في الحالات اللي احنا بنعمل لها سنتين الليمف نود، وانا هبعتها لحضرتك علشان تقطعيها. if there is micro invasion of the sentinel lymph node, it is different in lymph node post adjuvant chemotherapy than the upfront surgery.
Yes, yeah. So post-neoadjuvant chemotherapy, the micromets or even isolated tumor cells would make it not pathological complete response. So this tumor did not respond, and we think that this is resistant disease. So this is disease that actually did not respond to chemotherapy, and it is resistant. While isolated tumor cells and micromets in the standard without chemotherapy, we can ignore them. We wouldn't go back and do axillary dissection or anything. But in the context of neoadjuvant chemotherapy, this is not PCR, and this is resistant disease. And most people actually in the UK would go back and do axillary clearance if there is micromet after neoadjuvant chemotherapy. But most importantly, not to call it PCR, even if they are ITCs.
هو ده بس اللي انا كنت عايز اشرحه للشباب اللي موجودين معانا، ان لما يبقى في مايكرو انفيجن في حالات البوست اوبراتيف بوست ادجuvant chemotherapy is different in decision than with upfront surgery without adjuvant chemotherapy. Okay,
Yeah.
thank you. Another question برضو lymphovascular invasion post new adjuvant chemotherapy, it is complete pathological response. ده هو بقى خرج بره اللي انا كنت بقوله، بيتكلم دلوقتي عن lymphovascular invasion. If it is
Yes,
still
this is a pure pathological question. So
yes.
yeah, we would not regard this as PCR. This is residual disease in the form, residual invasive in the form of lymphovascular invasion. And as the pathologists in the audience will know, sometimes in a minority of cases, we get just lymphovascular invasion only. There is no stromal invasion and nothing else, just emboli in vessels. And these are not PCR. These are regarded as residual disease, residual invasive in the form of lymphovascular invasion. And discussion with colleagues and the experts, they recommend, if you're using the residual cancer burden, to use the size of the LVI as the size of the invasive tumor as well, as an approximation. Yeah, but it's not PCR, it's residual disease.
اوكي. طيب في حد له اي سؤال تاني؟ عشان احنا يعني سهرنا دكتورة عبير معانا.
لا ده انا اللي سهرتكم على فكرة، انتوا ahead،
لا
انتوا 2 hours ahead.
بس احنا مستمتعين الحقيقه، واحنا
الله
يعني
يخليك.
انا فعلا فيري يعني حضرتك بتعملي فيري جود ورك الحقيقه دكتوره عبير.
الله يخليك.
طيب حد تاني من الزملاء محتاج اي سؤال من دكتوره عبير؟ طيب محدش رد عليا. لو ما فيش احنا هنشكرها، واحنا لينا طلب اخير عندها، ان يبقى في مره تانية وثالثه، وحضرتك تحدد لنا بقى الميعاد اللي حضرتك تكوني افيلابل فيه. هبقى اتواصل مع حضرتك يعني نشوف الميعاد اللي حضرتك افيلابل فيه، عشان يعني تبقى معانا مره تانية، ويكون في ميعاد مناسب لحضرتك ان شاء الله يا دكتور عبير.
بإذن الله، يشرفني دايما والله، وأنا سعيدة جدا جدا إن أنا تقابلت مع زمايلي ولاد بلدي والنماذج المشرفة في التخصصات كلها، الباثولوجي والسيرجري والأونكولوجي. Really pleased to be with you today. وإن شاء الله just let me know what topics will be of interest to you. أنا المرة دي يعني that's what I thought would be of interest, but if there is anything in particular you would like to cover next time, إن شاء الله we'll be with
لا
you إن
احنا
شاء
نحب
الله.
نسمع اللي حضرتك عايزه تقوليه في اي وقت. احنا مش هنختار لحضرتك، احنا هنسيب العناوين اللي حضرتك تختاريها.
خلاص بإذن الله، إن شاء الله إن شاء الله على لقاء، ونشوفكم على خير قريب بإذن الله إن شاء الله.
احنا شرفنا جدا بوجود حضرتك معانا، وانا بنقل لحضرتك يعني شكر وتحيات كل الزملاء اللي موجودين معانا، وانا حاطط لهم على الجروب اهوت اللينك بتاع تسجيل السيمينار بتاع النهارده بتاع الدكتوره عبير شعبان، وهبعته لك على الواتساب الدكتوره عبير. وانا
خلاص إن
حاطه
شاء
تاني،
الله.
هحطه تاني على صفحتي وعلى صفحه اسم الجراحه طب اسوان، وعلى الجروب بتاع المكتبه. احنا عندنا جروب، في جروب مكتبه اسم الجراحه عليه دلوقتي 101، هيبقى 102 آه، يوتيوب التسجيل للسيمينارات. شكرا جدا يا دكتور عبير، وشكرا لحضرتك، ويعني كل سنه وحضرتك طيبه ورمضان كريم، متشكرين لسيادتك جدا يا فندم.
الله أكرم، ألف شكر وبالتوفيق جميعا إن شاء الله، ونشوفكم على خير دايما بإذن الله،
ان شاء
كل
الله
عام
نشوف حضرتك
وأنتم
قريب ان
بخير.
شاء الله.
إن
كنت
شاء
طيبه
الله
وكنت
إن شاء
بخير.
الله.
مع
في
السلامه.
أمان الله، السلام
مع
عليكم.
السلامه. شكرا للحضور كلهم، شرفتوا.